Hi, how are you today? Good. First, I have to apologize for something. If you see my kitten playing behind me, please don't be distracted. Today they are awake and they are playing around me. So you may see them uh, walking on my desk. Uh, and the next thing, yesterday I paused the recording of the session for a while and I forgot to play it again. So yesterday's session was not recorded. And on weekend, I will record it again and upload it for you. So that's why I didn't upload the yesterday's session to YouTube. I have to record it again. Sorry. So let's move to last week. We discussed and watched some videos about the old technique of plate fixation. It was rigid fixation and using dynamic compression plate, DCP. Uh, the concept is still in use, but the plates are not in use, almost are not in use anymore, at least in developed countries. In a few years ago, a new concept developed by the AO Foundation in Switzerland uh, called locking plate. And it really revolutionized the concept of plate fixation in fractures. Locking plate means the screw head is locked inside the plate. So the screw is attached to the plate. All the problems that we had with non-locking conventional plates was solved by this new concept. And if you remember, we said the conventional plates worked based on the compression between the plate and the bone and the friction that this compression creates. So the bone cannot move over the plate or the plate over the bone. So they remain in place and hold the uh, fixation. And we discussed the problems that this compression here and this friction here can provide. And also, since the screws were not locked and were not attached to the plate, they could toggle, they could move, and biomechanically, when a load is applied to one side of the fracture site, this load is transferred through the first screw to the plate and then through the plate to the last screw and to the opposite side of the bone. So these last and first screws were under enormous pressure, stress, but the rest of the screws were relaxed and they were resting there. Once these two screws were failed, the stress were transferred to the next screws in line and so on. So in these plates, the failure happened in screws one by one. And this was a problem because the single screw cannot withstand an enormous stress applied by weight bearing. And in locking plates, these two basic concepts was changed. First of all, since the screws were locked into the plate, there was no need to compress the plate against the bone. So all the problems with this compression were solved. First of all, the biomechanical basis for creating the friction to prevent any motion was eliminated. We don't need that anymore. And also, the compression of plate against the bone created uh, mm, a vascular zone here because the blood vessels beneath the plate were under pressure, so there was no blood flowing through them, and this area of the bone directly beneath the plate became avascular and gradually dies. So here we don't have that problem because the plate doesn't need to be compressed against the bone, so the blood vessels here remain intact. And the second problem was also solved. The load applied to one side of the fracture, in contrast to the conventional plates, it was distributed in all the screws in ipsilateral to the fracture side. So the stress was distributed between 3 screws, or as many as the screws that we have here. Here we have 3 screws, so the stress will be distributed between 3 screws, almost evenly. And all these stress is passed through to the plate and to the other side of the fracture, and again distributed in all 3 screws on the other sides. So all screws are under the same amount of stress. It means that the stress in each screw is much lower than the stress in these 2 first and last screws in the conventional plate. So the failure rate will be lower. But there is a huge problem with this. This is the conventional plate hole, and this is a locking plate hole. There are some predetermined threads in the locking plate and some predetermined threads in the screw head, and they must match together. And as you know, they only match in one angle. So the screw could be placed only in one position, in one angle, in one direction. And this was the major problem. Uh, when we want to insert these screws, we have to align them with the hole, and this alignment must be perfect, so the threads are engaged perfectly. For this reason, we have another problem. Sometimes the plates are straight, but the bone have different shapes, and you may know the bone in different people may have different tiny differences. For example, my femur is not exactly the same as your femur. Generally, they are the same, but when you want to put a plate on them, there may be some slight different curvatures. And to match them, you have to bend these plates. If you don't bend these plates, the screws will not be aligned in the correct position in the bone, especially when we are working around the joints, which screws must be aligned exactly with the articular surface. So we have to bend these plates to match them with the shape of the external shape of the bone. But when we bend these plates, the threads will change a little bit. And this change may disrupt this engagement. So we couldn't bend these plates as easily as we bend the conventional plates, and we could easily bend those plates. But here, it's not as easy to bend it. So we had to create pre-shaped plates based on different locations we wanted to use the plate. We had to design different plates, and for each location we need to have a specific plate. So it created a lot of designs, but still it is working. Another, another problem was locking screws by themselves could not create any compression. If we needed to use the concept of old plates, which was creating compression on the fracture side, we couldn't do it with these plates. So they designed a hybrid hole, a hole containing a locking part and a compression part. The left side works as a compression screw, the same as the old designs, and the right side is a locking one. Based on your intention of how you want to fix your fracture, you can select one of these options for this specific hole. You cannot put two screws here, only one screw, but you can select which one. So in this 6-hole plate, 3 on one side, 3 on the other side of the fracture site, you can, for example, select 2 dynamic compression screws and 4 locking screws. You see here 2 small holes. You didn't see it previously on other plates, or you see it here also. These holes are for holding the plate, because I said for locking plates, we need to align them perfectly on the bone before we put the screws. With compression screws, we had some freedom to move the plate after we insert the screw. We can rotate it, we can move a little bit, but with locking a screw, once the screw is locked, everything is in place and we cannot change it. So to prevent any problem, we have to prefix the plate before inserting any screw, before drilling any hole. And these small holes are for using very tiny pins to fix the plate in place provisionally, provisional fixation. So the plate is in place, and now we can put the screws, and after, when we put some screws here, we can remove these pins. Uh, the first biomechanical advantage of this design is it is a fixed angle construct. All the screws are attached to the bone, to the plate. So as you see here, in the conventional plates, the screws will move and toggle inside the hole. So when we apply load, if the fracture site is not stable, they will toggle and gradually resorb the bone around the screws, and it will fail. But in locking screws, it will not happen. If the fixation wants to fail, since the screws can move, in a conventional plate, when the fixation is failing, it can easily fail because the plate can move and the screws inside it can change direction. So they can easily be pulled out of these widened hole. But for locking a screw, if it wants to fail like this, you see it cannot move directly outward. It has to bend because these are fixed angle and the screws must move attached to the plate. So creating such a defect is very difficult. So it prevents the failure. If it wants to fail, instead of in this shape, it must fail like this. The bone must move directly in one direction, and it is not something that happens in our body. So it keeps the fixation safe. And also, if we use the screws in different directions, if the plate allows us to put the screws like here at an angle, you see, if it wants to fail, it has to remove all this bone to let the plate and screws come out of the bone. And this is another way to keep the fixation stable. And if you see here, these plates are a little bit curved. It means that this screw and this one are at some angle. Although this angle is very small, but they form an angle with each other. So it keeps the structure more stable. And the next one is what we discussed about the load distribution in all the screws. And this is another way to keep the structure safe. The next one is, we discussed before briefly, and tomorrow we will discuss it in detail, that we have two kinds of bone healing in the fracture side. One is primary bone healing, which we intended to have it with our dynamic compression plates. But in all other plates like breech plating or locking plates, we have secondary bone healing. Secondary bone healing is stronger because it creates a callus for us here, and this callus has a larger diameter, and you know the stability in compression and bending is proportional to the force power of the diameter. So when the diameter of callus is here larger than the original bone, the stability here is larger. So we have a more stable healing process, which adds to the fixation. In locking plate, since we do not provide any compression unless we use those dynamic holes, that is an exception. But usually we don't use any compression, so we will have a secondary healing, not a primary healing. We will have a gap in the fracture site, and this gap provides secondary healing. And also, this gap provides a little bit motion. This little bit motion provides strain, and we discussed in the previous session that between 2 to 10% strain at the fracture site is good for secondary healing and gives us a secondary healing process, which is in favor of union. When we want to use the locking plates, we must follow some rules. First of all, locking plates needs preoperative planning. All orthopedic surgeries needs preoperative planning, but many conventional procedures are performed without preoperative planning. But for locking plates, we need careful preoperative planning. We must know where to put the plate. When we want to drill the holes, we must use drill guides because we must drill exactly in the direction of the thread. So we need a drill guide, and then we need to use an appropriate drill bit to create the hole and measure the length of the hole correctly. And then we need to put a screw in place. Uh, Again, we need to, beside engaging the screw with bone, we need to engage it with the plate. And these are two separate processes that we must be careful about them. And then at the end, like any other procedures in orthopedics, we need to confirm that everything at the end is correct. Uh, the best way for preoperative planning that almost all the surgeons are familiar with is using the X-ray. Sometimes we need CT scan to see inside the bone to see if there is any problem inside the bone, but usually the plain X-ray and AP, anteroposterior view, and a lateral view is enough for us. We must draw the bone on it and be sure that if you have any segments, any extra pieces, and then put these segments together and actually reduce the fracture. And then when we reduce it, we put an imaginary plate based on what we have in mind. And based on this plate, we can select the screws, the orientation of the screws, and the length of the screws. And at the end, during the surgery, we do the same, because these screws are selected based on the biomechanics of the plate. For example, we know that in femur, if we want to fix a plate, we only need 4 screws on one side of the fracture side. So although we have a large plate here, but we don't need to put all the screws here because it creates a very rigid structure, and we don't need that. Also, in this preoperative planning, you see the plate is, although the bone is aligned with the knee, but we don't need to attach the plate to the bone. And you see here, the same thing happened. So preoperative planning helps us to create a good result. And beside that, it will increase the speed and the speed of the surgery, and it decreases the time of the surgery, because we know what we want to do and we exactly do that, and we don't need to think about anything in the surgery unless something happens. Next, we put the plate where we want. And as you see, we have a small holes here. We can fix the plate in place. And these locking plates, which are created for each bone, only will be matched to the bone in one location. So we must find that location, that best location for this plate, and then use a drill guide. This drill guide will be locked inside the threads of the plate. So it will be in exact direction of the threads. Now we use a drill bit through this drill guide and make a hole. This drill bit, the size of this drill bit, the diameter of this drill bit must be exactly the size of the core diameter of the screw. The core diameter is the diameter of the central part of the screw. If you remove the threads, the part that remains is called core. And that is the diameter of the drill bit. So we create a hole that can accept the core of the screw, but the threads must find their way in the bone, not in the hole. That is why they can hold the bone securely. And when we create the hole, we use a depth gauge. Depth gauge is a device to measure the depth of the hole we created. It is non-invasive because sometimes on the other side of the bone, there are some critical structures, for example, arteries, nerves, and it must be truly non-invasive with blunt tip, not to injure that area. And when we measure the size, we select a screw. A screw can be self-tapping, which means it has a slot at its tip that can create the threads inside the bone. And this area, while moving inside the bone, creates the threads. And so the threads can pass through these created parts. Sometimes, instead of drilling, we can use self-drilling screws. They have a tip exactly like a drill, and it can drill through the bone and then tap it, and we can insert the bone screw. It was a novel idea at first, but gradually it showed that it is not practical. Today we barely use these screws unless we want to put the screw in only one cortex. Consider for one cortex, it is perfect because it works as a drill and cut its way through the cortex, and the rest of the screw moves forward behind it. But once the drill reaches the second cortex, it happens for all the drills, not only this self-drilling screw. When you are using a power drill and you reach a hard surface, at first the drill is turning, but it's not moving forward. After a while, when the surface is cut, it moves forward. So for a few turns, the drill is turning without moving forward, okay? The same thing happens here when the tip of the self-drilling screw contacts the second cortex. When it contacts here, for a few turns, it is turning, but it is not moving forward. But here, the threads are engaged with the bone, with the first cortex, and they are engaged. But consider they are turning and they are not moving forward. So they are cutting their threads in the bone. And actually, they are creating a larger hole around their threads for that few turns. And when it moves forward and creates the hole in the second cortex, and the screw is fixed in the second cortex, the screw loses its fixation and threads in the first cortex. That is why we no longer use these self-drilling screws for bicortical fixation. If we want to use a unicortical fixation, yes, they are practical because they eliminate one step. We don't need to drill the hole, and we can directly use the screw, self-drilling screw by a power drill and fix the screw. But for bicortical fixation, they are not useful and they jeopardize the fixation in the first cortex, so we no longer use them. So whichever screw that we select, another problem with these screws is since we don't have a pre-drilled hole here, we cannot measure the length directly. we have to use an X-ray to measure the length, and these measurements usually are not accurate as the measurement with a depth gauge. This is another problem with the. So once we have the hole here, we want to put the screw. First, the threads on the locking screws, the pitch of the threads, the space or the distance between the threads on locking screws is very small. So if we want to use a screwdriver to insert a long screw in the bone, uh, it takes a long time to uh, do it. So we usually use a power drill to insert the screw for the first part, but the last part, which is engagement of the locking head with the plate, which is engagement between two metals, must must be done with a screwdriver, not with power drill. And again, we don't rely on the strength of the surgeon for this engagement. There are some specific uh, screwdrivers that when we use them, they apply a specific force, and if you apply more than that, they will release and they will not tighten the screw. So a specific amount of force is applied for tightening the screw inside the plate. If you apply more force, it will cause cold welding between the metal in the screw head and the metal in the plate. And if you want to remove the screw later, it is impossible because there is an attachment. Instead of engagement of the threads, there is an attachment between the screw and the plate, and you cannot remove the screw from the plate later. And that is not something that we want. As you see here, the threads are the pitch of the threads are very small. And you see three different screw types: self-drilling, self-tapping, and regular one. For this regular one, you need to tap the hole. When you drill it, you need to use a tapper to create these threads to allow the threads of the screw to pass through the hole and engage with these threads. For self-tapping screw, the tapper is attached to the tip of the screw, and you don't need the tapper, but the tapper is here and it creates the threads and allows the screw to be inserted. These are the most screws in use now. And this is a self-drilling one, which creates the hole, and I discussed why we do not use them today. Another thing to remember about these screws is if we consider here as the end of the other cortex, the other side of the bone, this screw must pass through here until the last complete thread. The last complete thread must be engaged with the other side cortex. So only a small tip will protrude through the bone here. But the last complete thread in self-tapping screw is here. So this large area must protrude through the bone, which is sometimes problematic, specifically when the other side of the bone is under the skin, like in forearm or sometimes in leg. The other side is under the skin, and if they protrude, they will irritate the soft tissue. And here you see the last thread is here, the last complete thread. And a very large part of the screw must be protruding through the other side of the cortex. Otherwise, if we do not incorporate all these complete threads with the other cortex, the fixation is not stable enough. I told you before that one of the major problems with locking plates is screw alignment. First, alignment of the screw with the threads. We must put the screw exactly in the direction of the threads. You see here, if you put the screw a little bit off the direction of the threads, the engagement between the threads on the screw head and the plate hole will not be complete, and this is not an optimal fixation. When we use this direct direction, and we know that the screw can be placed in the plate only in one direction, sometimes this direction is not what we want. For example, maybe there is a hairline fracture in the bone beneath here. And if we put the screw in this direction, we will open that hairline fracture, and we don't want to do that. So either we have to skip this hole, or we need to put the screw in another direction, and we cannot do that. So this is one problem. Screw size must be measured correctly. I explain it for you. And sometimes the bone quality is another problem for us. Specifically in areas that the patient has osteoporosis, poor bone quality. It means that even the locking screws will not engage with bone correctly, so the structure may fail. There are some measures to prevent it. One of them is using bone augmentations here that we will discuss later. So to solve the most important problem of the locking screws, that was screw direction, there have been some measures to solve it. This is a conventional locking hole. You see the threads are continuous. And when you insert the screw must engage with all of them one by one until the screw is locked inside the hole. One solution to this problem was, instead of that continuous thread, they created a larger hole with these separated threads. And these threads are designed in a way that instead of matching the first one with this one, with the first one on the other one, you can match the first one with the second one, with the third one. So you can tilt the screw, and as you see here, you can change the direction of the screw a little bit. Again, here, you see, you cannot change the direction. You cannot match these, the first thread on the screw here with the second one on the other side, because they are continuous. When you engage the thread here, it must continue engagement. But in this one, since they are not continuous, when you engage with this one, you can engage it with the second one on the other side, not the first one. So you have a little bit freedom in changing the orientation of the screw in these holes. And it was the first step to solve this problem. It gives you some freedom, but it is not sometimes enough. That is why something else was created, and we call them polyaxial locking holes. These holes allow you to change the angle of the screw almost as much as you want, almost as much as the hole allows you. Sometimes maybe up to 20 to 25 degrees, you can change the direction. There are several mechanisms for this. One of them was applying a mechanism inside the hole. The hole is cylindrical or conical, and a part of this hole contains a metal that is a little bit, not too much, a little bit softer than the plate and the screw metal. And the threads on the screw head are in a way that they can cut into this metal. So you determine the direction of the screw, and when you insert the screw and tighten it, when it reaches this part of the plate, it cuts its thread into this metal and stays locked. It cannot cut into the plate. It can only cut into this specific part in the hole. This specific part may cover the whole area of the hole, or it may be just as a ring here. But it's a good mechanism. It is practical. And when you insert the screw, it remains in place, and it has worked up to now. But it has two problems. Since you are cutting the threads in a metal, the risk of cold welding is high. So later, when you want to remove the screw, there may be some problems. The second problem is when you insert the screw and you encounter a problem, for example, the length of the screw was not correct, you want to change it, or the direction is not perfect and you want to change it a little bit. The second time you want to thread into this metal, it will not give you the same purchase as the first time. So it is only good for one-time insertion. The next one was, maybe we call it a genius design, and now it is in widespread use. It is a locking cap mechanism. The hole is circular.
Quick question about the polyaxial ones, or you're saying that two of the problems are cold welding, but if they're cutting into the plate, wouldn't another factor be like the metal shavings, or?
Yes, yes, that is another problem. Some shaving products may be there, but it is very tiny. But that's a problem. Yes, that is another problem. So here in locking cap mechanism, the hole is circular, and inside the hole in the plate, there are some threads that match the threads on a cap. This cap is separate from the screw. The screw is almost the regular one, similar to the other screws, with the head that matches inside the cap. We put the screw at any angle that we want, wherever we want, inside the hole, and then we insert the cap over the head of the screw inside the plate hole. and gradually tighten it and lock it in place. These caps may have some locking mechanisms for additional security, but when they are locked in place, this screw cannot move anymore, and actually it is locked in place. Since we are not making any new threads, we are only just making engagement between these threads. The risk of cold welding is low. The risk of metal shaving you mentioned is almost ignorable, and we don't create any metal shaving here because the threads are already there and the direction is exactly the same. And the screw can be in any direction. And these are now the best option for our locking plates. Another one is a movable bushing inside the hole called expansion bushing. And this bushing can turn in different angles. When we put the screw is conical, the head of the screw, and when we tighten the screw inside the bushing, actually the bushing expands and put friction force on the size of the plate hole and stays in place. This is another good mechanism. It is usually used in areas that we have problem with access. For example, in pelvic surgeries, we cannot put the screw and then put another cap on it for locking. It's very difficult in the pelvis when you don't see anything in the deep areas in the pelvis. But with this mechanism, when you find the direction of the screw, you can put it, and then when you tighten it, the bushing expands and everything will be in place. It is not as rigid as the other mechanisms, but for what it gives us, it's a perfect choice. Another mechanism that is under investigation is expandable head. It is like expandable bushing, but instead of having a bushing here, the head of the screw expands. It may have some mechanisms like lock inside it to open that lock and the head expands, or a cone inside it. When you compress that cone, it expands the head. Whatever it is not in clinical use yet, but they are working on it. The head of the screw, which has several parts, it expands and come into close contact with the plate hole and remains in place. Since it is not in clinical use, we cannot say if it is better or worse than the other parts because it is under investigation. Any other questions? No? So let's watch some videos.
The principle of the internal fixator using the locking compression plate, or LCP. The objective of this presentation is to understand.
First, do you hear the sounds of the video perfectly? Okay.
The principle of the internal fixator. Demonstrated are the internal fixator protecting an independent lag screw, the internal fixator bridging a complex fracture, the internal fixator as a buttress plate, and the advantages of angular stability in osteoporotic bone. The plate used will be the 4.5/5.0 LCP. The unique combination holes allow this plate to be used with standard 4.5 mm Cortex screws or 5 mm locking head screws. The standard 4.5 millimeter Cortex screws are placed in the unthreaded portions of the combination hole, in other words, the dynamic compression unit. Wide angulation of the screws is possible. Cortex screws can be used to fix the plate onto the bone in the conventional way, or to achieve dynamic compression of the fracture when inserted eccentrically and tightened. Axial preload and friction between plate and bone provide stability. The threadless part of the combination hole always faces towards the end of the plate. The space between the two inner combination holes, whose thread portions face each other, represents the center or middle of the plate. Based on this symmetry, dynamic compression can be brought to bear from both ends of the plate. The 5 millimeter locking head screws are only used in combination with plates. The locking head screw is inserted in the threaded part of the combination hole. The head itself will lock firmly in the plate when driven home, thus providing angular as well as axial stability. The plate is not pressed onto the bone surface to achieve fracture fixation. A locking head screw is characterized by its threaded head, its larger core diameter of 4.3 millimeters, and a shallow thread. The green self-tapping screw has cutting flutes as well as a rounded tip. This is the screw used for the exercises. The blue self-drilling self-tapping screws have a drill bit tip as well as cutting flutes. The self-drilling version should only be used in the diaphysis and as a monocortical screw. If used in a bicortical fashion, the long and sharp drill tip could damage any structures outside the bone. Both screws can be used only in combination with an LCP. Needed to insert the locking head screw are 2 LCP drill sleeves, the 4.3 millimeter drill bit, which corresponds to the diameter of the core of the screw, the depth gauge, the 4 Newton-meter torque limiter, the handle and the screwdriver shaft. The large torque indicating screwdriver can also be used. The internal fixator bridging a complex fracture. This exercise will demonstrate the use of the LCP system in combination with the MIPO technique, or minimally invasive plate osteosynthesis. The second layer of black foam on the bone simulates the soft tissue envelope. First, the anatomical reduction, that is, the length, axis, and rotation of the two main fragments, must be restored. This reduction may be achieved by indirect reduction techniques, such as manual traction, or the use of a distractor, a temporary external fixator, or a traction table. In clinical practice, the objective is to minimize the additional trauma to the fracture zone by using no direct manipulation of the fragments. The 12-hole LCP will be used to bridge the fracture. The plate is held against the bone with the LCP drill sleeve. The required position is adjusted using the image intensifier. At one end, a small incision is made down to the periosteum. The plate is gently introduced and slid under the soft tissue cover in the epiperiosteal layer. During insertion, the position of the plate should be monitored with the image intensifier. Here, the advancement of the plate can be checked visually. After palpation of the plate, a second short incision is made to allow the second drill sleeve to be firmly screwed into the end hole of the plate. The reduction of the fracture, as well as the position of the plate, should be checked once more. The plate is now fixed to the bone at one end by a locking head screw inserted bicortically. Drilling is done with the 4.3 millimeter drill bit. The drill sleeve is removed, and the depth is measured. A green self-tapping locking head screw is inserted with the power drill. Although the last few turns must be done by hand with the torque-limiting screwdriver in order to prevent over-tightening. At this stage, the reduction is again checked. Length, alignment, and rotation of the bone must be correct. Minor reduction adjustments can be performed indirectly using the drill sleeve. Once correct reduction has been achieved, the 4.3 millimeter hole for the locking screw is drilled. The drill bit has to be left in place. It's important to realize that with one fixation device per main fragment, any correction of length or rotation is no longer possible. However, adjustment of the axial alignment in one plane can still be carried out. Another plate hole is found by palpating the plate surface. If necessary, the image intensifier can be used to locate the holes. After incising the skin, the second drill sleeve is carefully inserted, and the second 4.3 millimeter drill bit is used. The corresponding self-tapping locking head screw is inserted. Only now are the drill bit and drill sleeve removed from the end hole and another locking head screw inserted. Additional locking head screws must be inserted, avoiding the comminuted fracture zone. At least 2 screws per main fragment are required. As bridge plating with an LCP provides relative stability only and protects the bone vascularity for its entire length, bone healing by callus formation will be enhanced. Removing the outer foam layer shows that relative stability is achieved with no compression of the plate on the bone and no interfragmentary fracture compression. The fracture area has been bridged by the plate. First, the internal fixator, protecting an independent lag screw which provides absolute stability. The short oblique distal tibia fracture.
Let me explain the concept of lag screw. When we have oblique fractures, we in the previous concept that we wanted to apply the compression to every fracture, we couldn't apply the compression through the plate in oblique fractures because they slide over each other and the reduction was lost. The lag screw mechanism was developed to compress these 2 oblique fracture. If this is the bone and this is another bone, you see the fracture, if was transverse, the compression was perfect. But if the fracture is oblique, when we compress this bone together, they slide over each other. So we have to do something to compress them. And the best way is to compress them perpendicular to their orientation. It means perpendicular to this plate, which is this orientation. So we can use a screw to compress these 2 together. You see here, to do that, you need a lag mechanism. The lag mechanism means engaging the screw only in the far cortex, that when you tighten the screw, it is pulling the far cortex toward itself. In other words, the screw that is passing through the near cortex and engages with the far cortex, in the near cortex, it has no contact with the bone. To do that, you need to create a larger hole in the near cortex that allows the screw to pass through it without any engagement. This is the foundation for lag mechanism, creating a large hole in the near cortex, creating a standard hole based on the size of the core of the screw in the far cortex. And the orientation of this screw must be perpendicular to the plane of the fracture. And then when we tighten the screw, we compress these two oblique surfaces. Now let's
Fracture is anatomically reduced and held with the pointed reduction forceps. As the first step, a 4.5 millimeter lag screw is inserted in the AP direction. The glide hole is drilled with the 4.5 millimeter drill bit and protection sleeve. The 3.2 sleeve is inserted into the glide hole and the thread hole in the far cortex is drilled with the 3.2 millimeter drill bit. On the tibial crest, countersinking is necessary, otherwise the screw head is too prominent. The screw length is measured with the depth gauge. And the far cortex is tapped. A 4.5 millimeter cortex screw is inserted to provide interfragmentary compression. The reduction forceps is removed. Here an inadequately contoured LCP fixed in a conventional way is shown. When the last screws are tightened into the poorly contoured plate, the fracture dislocates. This disadvantage does not arise if an LCP with locking head screws is used. Therefore, this plate does not have to be pre-shaped absolutely anatomically. The LCP has been slightly bent at the distal end. The plate with the LCP drill sleeve screwed into the most distal hole as a handle is gently inserted and slid along the medial aspect of the tibia. As the locking head screws cannot be angled, care must be taken when positioning the plate to prevent screw penetration of the joint. Moving proximally, the plate does not touch the bone, nor will it need any additional contouring or torque. The most distal hole is drilled with the 4.3 millimeter drill bit through the drill sleeve that has served as an insertion handle. The drill sleeve is removed, and the length is measured with the depth gauge. The green self-tapping locking head screw is inserted with the torque-limiting screwdriver attached to the power drive. The last turns have to be done by hand to prevent the thread from jamming, so the power drill is exchanged for the handle of the screwdriver. At this point, if the other end of the plate is not well secured, the helicopter effect will be created. Therefore, before completely tightening the first screw, the plate is fixed to the bone using the most proximal screw hole. The LCP drill sleeve is gently screwed into the threaded part of the combination hole. To make sure that the sleeve has been placed correctly, its purchase in the screw hole has to be checked. Here it is moved sideways, which means that it has to be reinserted. Once the thread has found a firm hold in the plate, the sleeve will not move. The second sleeve is fixed into the fourth hole from the top. Holding the plate firmly with the sleeve, a 4.3 millimeter hole is drilled bicortically through the most proximal plate hole. The drill sleeve is removed, and the screw length is measured with the depth gauge. A self-tapping locking head screw is inserted. The screw head is locked in the plate by hand with the torque-limiting screwdriver. When the maximum of 4 Newton meters is reached, a click is heard and felt. The screw in the most distal hole is now tightened. The hole for the second bicortical screw in the proximal fragment is prepared. The screw length is measured.
So the rest is the same. You see how locking a screw is fixed to the bone, and it is, sorry, the same thing.
The principle of the internal
hole and 3.2 millimeter thread hole are aligned. Internal fixation with screws and plates will be shown and practiced. There are 2 main sections: screw technique and conventional plating. The objective is to develop an understanding of the principle of interfragmentary compression that provides absolute stability.
This is
A 6.5 millimeter cancellous bone screw is used to demonstrate interfragmentary compression of a medial tibial head fracture with a lag screw.
with locking plate.
The following instruments are required: the pointed reduction forceps, a 1.6 millimeter K-wire, the 3.2 millimeter drill bit, which has the same diameter as the core of the screw, the 6.5 3.2 double drill guide, the depth gauge, the 6.5 millimeter cancellous bone tap, which has the same diameter as the thread of the screw, the T-handle, and the large hexagonal screwdriver. The fragment is reduced and secured to the bone with the pointed reduction forceps. For preliminary fixation, a K-wire is inserted parallel to the joint, avoiding the previously planned position of the screw. The hole is drilled with the 3.2 millimeter drill bit and drill sleeve without penetrating the opposite cortex. The depth is measured. The neocortex is tapped with the 6.5 millimeter tap and sleeve. In young patients with good bone quality, the entire length of the hole should be tapped. A 6.5 millimeter cancellous bone screw with a short thread and a washer is inserted. In its final position, the entire threaded portion of the screw must lie beyond the fracture plane to achieve interfragmentary compression. The required compression is achieved by tightening the screw. With dense bone, a washer may not be required. The reduction forceps and the K-wire are removed. Depending on the fracture pattern, a second screw or a buttress plate may be needed. The first part of this exercise will show the LCP used as a standard dynamic compression plate. The unthreaded half of the combination hole, known as the dynamic In this exercise, the use of an LCP-L plate as a buttress plate will be demonstrated. Intra-articular fractures are usually caused by shearing and bending forces. Often, fixation solely with lag screws cannot prevent secondary displacement in such poor quality bone. This displacement can be overcome with the application of a plate that serves as a buttress. The following instruments are required: the large pointed reduction forceps, the 1.6 mm diameter K-wires, the 3.2 mm diameter drill bit, the 4.5 3.2 universal drill guide, the depth gauge, the large hexagonal screwdriver, the 4.5 5.0 threaded drill sleeves, the 4.3 mm diameter drill bit, the screwdriver shaft, the 4 Nm torque limiting attachment, and the torque limiting screwdriver. A split wedge fracture of the lateral tibial plateau is reduced anatomically and held in place with the large pointed reduction forceps. A pre-contoured L plate is used as a buttress plate in this type B1 tibia plateau fracture. However, it may need additional contouring to the bone. Otherwise, it could either fail to buttress or it could cause a deformity when secured to the bone. Once the plate fits the contour of the bone exactly, it is securely fixed to the bone. Two 1.6 mm K-wires are inserted at 90 degrees through the plate to the fracture plane so as not to counteract any subsequent compression. It is best to start the fixation of the plate on the diaphyseal side. The plate is fixed to the bone with the screw in the neutral position in the usual manner. The depth gauge is used to determine the necessary screw length. To secure the split wedge fragment, a locking screw can be inserted. After drilling with the 4.3 mm drill bit, the depth is measured. The screw is inserted, and final tightened manually using the torque limiter. The second screw is inserted in the same manner. The most distal plate hole is filled with a 4.5 mm Cortex screw. The K-wires are removed. The third proximal plate hole is filled with the third locking screw. The reduction forceps is removed. The fit of the buttress plate is snug. Compression has made the fracture line almost invisible.
So there are two more videos. You can watch them if you have any questions. You can ask me. But I just wanted you to become familiar with how the locking screws are used and which devices are necessary for their insertion. I hope by next week, Wednesday next week, the virtual reality system is up and running. So we will just have some discussions about the concept, and you can move on to the virtual reality goggles. I hope it happens next week, because today I just set up a meeting with the support department of the company on Friday, so I hope everything's move on. If you have any questions, otherwise, see you tomorrow at 5. Okay?
Have a good night.
Good evening. Enjoy.
Good night, Professor.
Thank you.
Thank you.
Thank you. Bye. See you.